So as you're all aware, today is actually our last pulmonary and critical care grand rounds of the year, and also our annual Nair Endowed Lecture. And so I'm just going to talk a little bit about Dr. Nair before introducing our visiting speaker. So Dr. Nair was a major national and international leader in pulmonary medicine. He came to the United States from India and trained in pulmonary medicine in New York City. He was one of the first physicians to take and pass the ABIM examination in pulmonary medicine. Sri, as he was affectionately known by his many friends and colleagues, practiced at Norwalk Hospital in Connecticut, where he was chief of pulmonary and critical care medicine for 24 years. In the mid-70s, Dr. Nair founded the National Emphysema Foundation, supported largely by his many grateful patients. And for more than 5 decades, his foundation has funded research projects in Connecticut and throughout the U.S. and has been a major source for lecture support at academic medical centers, including Yale. He was also a founding member and past chairman of the International Society for Computers in Critical Care and Pulmonary Medicine and a consultant to the World Health Organization. The American Thoracic Society awarded Dr. Nair the International Health Award for his contributions to pulmonary medicine in India and other countries. With his wide vision and wisdom, Sri was a supporter of telemedicine years before it became important in the United States and throughout the world. After Sri's death in 2014, his family and the National Emphysema Foundation endowed an annual lecture in his honor at Yale. We are delighted to have Dr. Hallie Prescott as our 12th annual Sreedhar Nair visiting professor and pulmonary and critical care grand round speaker. Dr. Prescott completed medical school, internal medicine residency, and a chief year at The Ohio State University before moving to the University of Michigan. At the University of Michigan, she completed a fellowship in pulmonary and critical care medicine and a master's degree in healthcare research before joining the faculty in 2014. She rose through the ranks and was promoted to professor of internal medicine at the University of Michigan Medical School in 2025. Dr. Prescott is also the Toes Family Legacy Professor of Pulmonary and Critical Care Medicine and a core investigator at the VA Center for Clinical Management Research. Clinically, she works as a staff physician at the Ann Arbor VA. The primary focus of Dr. Prescott's research has been on the epidemiology, management, and outcomes of sepsis. She is internationally recognized for her expertise in sepsis. She co-chaired the recent 2026 Surviving Sepsis Campaign Clinical Practice Guidelines, serves as a council member of the International Sepsis Forum, and leads a 68-hospital sepsis quality improvement initiative funded by Blue Cross Blue Shield of Michigan. She has been recognized for her research contributions by awards from the American Thoracic Society and the American Society of Clinical Innovation. We are delighted to have her with us today as this year's Nair lecturer, and she will be speaking to us about the Surviving Sepsis Campaign Guidelines, what is new and different in 2026. Thank you for being with us, Hallie.
Well, thanks so much, Lauren, and all of you. It's really an honor to be here. It's already been a really fun day. It's always nice to go places in person. It's my first time to Yale's campus, and I'm looking forward to sort of touring the undergrad area with Lauren later today. So yes, as mentioned, I'm going to be talking about the guidelines published in March. This is the disclosure slide. I have one financial disclosure. I serve as a scientific advisor to Arabec Therapeutics. They have nothing currently on market, so really not pertinent to the guidelines or today's talk. And so without further ado, I'll get going. So I'm going to start off and talk about the methods. I think, sometimes kind of like how guidelines come to be and the processes can be a little bit nebulous and black box. So I'll try to demystify that. These are really long guidelines with lots of recommendations, so I'm not going to go through everything here, but really try to give the highlights, what I think are the sort of more pertinent, like new or revised guidance, and then love to leave time for questions and answers, really anything related to the guidelines, happy to address. So first, I'd really like to acknowledge the whole panel. We had a really diverse and committed panel of 69 members coming from 23 different countries. 38% of the panel practice either currently or previously in a low or middle income country. And that was really sort of important given that the large burden of sepsis occurs in lower and middle income countries. And obviously resources there are different, and we wanted to be able to sort of address that in the guidelines. Of the 69 members, 25 were appointed by sponsoring professional societies. So those are societies, they're invited to, sponsor the guidelines, have a representative. And then the remainder of the guideline was appointed by me and Massimo Antonelli, who were the co-chairs, essentially with approval by the sponsoring or sort of funding professional societies, FCCM in the US, and then European Society of Intensive Care Medicine. And then, being funded by professional societies in North America and Europe, that's where the bulk of panelists came from, but 35% currently work outside of those two regions. So once we had made this panel of members, people got assigned to work in one of 6 different working groups. So these were essentially different clinical areas addressed by the guidelines and really trying to match people's area of clinical and research expertise to what sort of best suited them. We also had a systematic review team that did the bulk of the literature review and evidence synthesis. We had a patient and family panel that we worked closely with to ensure that, patient and family voices and kind of values and preferences were well integrated into the guideline. And then we also had what we called this usability work group, which was essentially really trying to workshop and make sure that sort of figures and materials to disseminate the guidelines were sort of easy to interpret and help kind of disseminate the recommendations. So at a high level, methods followed what are kind of pretty well-established standards for trustworthy clinical practice guidelines. And so the first step here is really defining and prioritizing what questions will be addressed, and then making sure that these are all in this PICO format. So that means we define the population. Is this people at risk for sepsis, with septic shock? What is the intervention? What is the comparator? And then what are the outcomes that we care about? And here we really limit to 6 or 7 clinical outcomes that we're going to focus on. And I think this is important to recognize that this kind of format of questions, because a lot of times clinically we want to say well, what's the best thing to do? Or what's the best way to do that? But that's not really how kind of systematic searches of literature work. And so we kind of have to, force ourselves to, organize our questions in this way. So once those are sort of sorted into PICO format, we then did systematic reviews. This was done by research librarians, methodologists, in close collaboration with the clinical experts for each question. Evidence synthesis, where we extract the relevant data, do meta-analysis, subgroup analysis, risk of bias assessment, and then ultimately grade the certainty of evidence behind each question. And that was done on an outcome-by-outcome basis. And so the sort of overall structure for assessing certainty of evidence is that based on the type of literature, whether this is randomized studies versus non-randomized or observational studies, things will start at being either high or low certainty evidence. But then there's a number of reasons for which evidence can be downgraded. That's because there's risk of bias, inconsistent results across trials, indirectness, which means the trial doesn't perfectly match the PICO question, but we're sort of saying it's close enough that it should be involved. And that could be because it's on something like distributive shock all cause, not specifically septic shock would be one example. Imprecision, that means there's a really wide, 95% confidence interval around this point estimate, and then publication bias. And then there's a number of domains by which we can upgrade evidence. That means if we see a dose response, a really large effect size, or opposing residual confounding, which basically means if we were to better control for confounding, if anything, the effect size would be stronger, not weaker or negated. And so then we come out with this ultimate assessment, again, for each outcome of whether there's high, moderate, low, or very low certainty of evidence. So next step, so after we've finished this evidence synthesis, each subgroup for their questions then goes through this process called the evidence to decision framework, which is essentially a worksheet they each fill out, where we go through the certainty of evidence, the balance of desirable and undesirable effects, which is often one of the most important considerations, hence bolded. But we also talk about the values and preferences related to like those particular outcomes that are impacted or the intervention, as well as resource use, equity, acceptability, and feasibility. And so the idea here is like by going through this structured process, like, you're making sure that you're making this kind of holistic evaluation. You don't like have your blinders on and just sort of focus on one outcome that was moved, but really kind of consider the totality of the impact of this intervention. So only after doing all that do we make a draft recommendation. And I will say that we get a lot of questions, or I get a lot of questions, the panel gets a lot of questions about like, well, why is there a statement on this, but a statement of insufficient evidence for something else? And so we made this figure that we iterated a lot to make sure that we were internally consistent, but then could also kind of convey, why things are as they are. And I'll just kind of walk you through this because I think the font's probably too small to read. But basically, you start at the top here and it says, if there is at least low certainty evidence, we will issue a graded recommendation. And that's different than other guidelines. So sometimes if there's evidence, but it seems to be that these two things, like the intervention and the comparator, are equal, people will make a statement of no recommendation. And we never did that. We committed that as long as there was low certainty evidence, we would say something. And then for the many cases where there's only very low certainty evidence, this was really considered on a case-by-case basis, and we try to explain this in the fine print, but basically this means we took into account other aspects, like the cost of something. If there's low certainty evidence that they're equal, but one's way more costly, we would suggest the other one. We also consider whether something's already widely in practice or like not being used at all, because there's kind of implications to those things, and whether to make a statement about them. And then we also consider whether we'd previously made a statement. We're very unlikely to stop making a statement about something we previously had commented on. So after that, we decide whether to make a graded recommendation, or if not, we consider whether to make either a good practice statement, which is not a graded statement, but just a sort of general suggestion, or a statement of insufficient evidence to make a recommendation. And then new for these guidelines, we pretty much systematically assessed whether it would be helpful to the field to have more information about what the panel is doing, right? We know how frustrating it is to say, well, insufficient evidence, we can't comment on this. And so for a lot of those statements of insufficient evidence, we surveyed our panel to say, well, what are you doing in your daily practice? And we do that as well in a lot of areas where we made a suggestion, but it was based on only very low certainty evidence. All right, so implications of statements. So those graded statements either come in two forms: strong recommendation or conditional or weak recommendation. And these are meant to be interpreted differently. So strong recommendations are much less common. These are things where you should really do this for all or nearly all patients. There's really less need for shared decision-making or tailoring based on clinical context. These are more appropriate for policy or performance measurement, and also areas where actually we should probably be spending less research dollars because we have really good information or guidance on what to do. By contrast, for conditional recommendations, these I think of as kind of like the rule of thumb, the default practice, do it for many patients, but there's more room here for shared decision-making and consideration of clinical context and sort of variation depending on those. These are less appropriate for performance measurement, and these are certainly areas where guidance may change going forward as additional research accrues and are worthy of more research. In terms of in the narrative write-ups in the guideline, we used a structured process to describing the effect size that's a little bit different than what is done in typical research manuscripts, where often the way we talk about things is simply based on like a p-value and the 95 confidence interval and whether that crosses the line of no effect. Guidelines, the recommendations are different. So this is a method that is recommended by grade, where we use standardized language that's like laid out on this table that basically is based on just two things. One, the point estimate from the meta-analysis, and then the certainty of evidence, which takes into account that imprecision, the 95% confidence interval, but is also based on the sum totality of certainty. So if we have a point estimate that there's moderate certainty, mortality benefit, but the 95% confidence interval crosses 1, we would still say, there's moderate certainty that this, reduces mortality by, and then the amount of difference would be based on that point estimate. All right, so after we have drafted the language, again, using these type of standard language, we then came together, we had an in-person meeting in March. This was at FCCM headquarters. So we brought together our full panel. 2 days, we had in-person discussion of these draft recommendations. My co-chair, Massimo Antonelli, was not able to join us, but had pretty much the world's best excuse. So he had been asked to stay behind by the Vatican because he's the chair of Department of Critical Care and was caring personally for the Pope. So that kind of made a good story for the guidelines. So I will say he was, I mean, I don't think he sleeps. He answers every email in about 10 minutes, but he joined us by video conference for the whole thing. All right. So after we discussed, this was really helpful, having people from 23 countries. You discover how often like things that you thought were crystal clear, other people might misconstrue and think that meant something else. And so you really sort of came at it and tried to make sure we were being clear about what we were recommending. And the panels, the subgroups all went back, tweaked language as needed. And about a month later, in April of 2025, we sent out our initial draft recommendations for voting by the panel. And so per the sort of pre-specified methods, we need at least a 75% response rate for each individual question and at least 80% agreement. And then I would say, in general, we had much higher agreement. So all but I think 5 of the statements in the guidelines had greater than 90% agreement, after this third round. And consistently, we had, very high response rates. Every now and again, there's life events, people are hospitalized, they can't get to something, and, they joined for the next round of voting. But by and all, very high involvement. All right. So what is in these guidelines? 129 statements, 44 of those were just directly carried over. We sort of triaged things that we said, well, we think this is likely to be the same. We're not aware of any like major evidence that's going to change it. And so we decided not to focus those as PICO questions, and we just put those to vote, yes, no, still relevant, and carry it over. And so those are very clearly like noted in the guideline that they're carryover statements and there's no narrative. So that's what 44 statements are. And then the rest of them were things that underwent formal evidence synthesis, all that stuff I just talked about. So 64% conditional recommendations. Again, that's the majority. There's a lot of times, a lot of gray areas where clinical context really matters and kind of shapes practice. 17 strong recommendations, 19 good practice statements, 11 statements of insufficient evidence to issue any recommendation, which should be clear research priorities. All right, so I'm going to walk through now and talk about what I think are some of the new and probably more maybe like novel or impactful new statements. So screening and early management, recommendation 2, we have a new suggestion for using code sepsis or sepsis huddle protocols to expedite diagnosis and treatment of sepsis. I think of these as kind of existing along a spectrum. Like a huddle is often like some kind of hospital protocol where they trigger the people actually caring for the patient already, like the nurse, the physician, maybe the unit pharmacist, and then the nurse manager, all to come together at bedside, quickly discuss the patient, decide if, yes, you think they have sepsis, and expedite those next steps of management, fluids, antibiotics, cultures, et cetera. Whereas a code sepsis is typically a more formalized protocol, either a response by the actual rapid response team, or there are some hospitals based on high volume of sepsis that actually have dedicated sepsis response teams that respond just to calls for sepsis and will go initiate and sort of expedite those additional steps of management. So, low certainty evidence, but this consistent signal that this does speed up processes and outcomes of care. Next, we have a suggestion to screen for sepsis in ambulance en route to hospital. This is based on very low certainty evidence, but based on kind of the sum total, this is easy relatively to implement. This is not costly. Was overall felt that the balance of effects benefited recommending this. And it makes sense, right? This is like a time-sensitive medical emergency. We do this already for things like heart attack and stroke, such that by the time the patient arrives to the hospital at handoff, we can say, this is what we think this patient has. And so the same thing can and happens in some places where at handoff from EMS to the hospital, we say, oh, we have this patient, based on the screen, we think they're likely to have sepsis. This can sort of expedite that treatment once the patient arrives. All right. Actually, this should be recommendation 6, but this next one I'll highlight is actually one of our statements of insufficient evidence. And this was to make a recommendation regarding use of novel rapid host diagnostics. And this has been an area where there's been a lot of technological innovation. And just in the past 2 years, there have been a whole number of these kind of diagnostic aids that have been approved in both the US and also Europe for diagnosis of sepsis. So I've listed a number of them here that are approved either in the US US or in Europe. And so there's a lot of interest from the field of like, well, gosh, which one's the best and which one should I be using? And so here we could only make the statement of insufficient evidence. Because again, if you go back to this kind of PICO process, like outcomes we prioritize are always going to be like processes and outcomes of care. All of these things really came to market based on their sensitivity and specificity relative to some kind of reference standard, but not because they've been shown to improve treatment or outcomes. And so we had a lot of hemming and hawing, like, should we suggest against them? They cost money and we don't know they help. But that felt like overly nihilistic, like who's ever going to invest in this field if we just like shoot them down before they can even develop data. So we came up with this very kind of carefully worded state or narrative explaining that due to the costs, due to the lack of evidence regarding patient-centered outcomes or resource use, the panel did not recommend use of any of these aids. However, studies evaluating the impact of diagnostic aids on patient outcomes and resource use are a priority, and thus it's reasonable for health systems and clinicians to make use of them when feasible, while studying their impact on outcomes and resource use. So again, you want to like push people to study these things. There's, good reasons why they may be helpful, but you also don't want, to people use their limited resources on things where we don't yet have data of how to integrate them into practice and whether they actually provide additional value above and beyond kind of already clinical tools in use to diagnose sepsis. All right. Next up, recommendation 10. Probably the most controversial recommendation in the whole guidelines, I would guess. This is about the initial fluid resuscitation, and this recommendation is really consistent with 2021. We do provide a lot of extra kind of remarks and narrative to help, sort of guide this. So we say for adults with sepsis-induced hypoperfusion or shock, we suggest administering at least 30 mLs per kg crystalloid within 3 hours. You'll hear a lot like, it's aggressive, my patient will drown. So we did provide this table that actually like shows how much fluid this ends up being. It's about 1.5 to 3.5 liters. When you think of the sum total of patients, maybe 2 to 3 liters for the vast majority of adults. So it's not a huge volume, over 3 hours. And then we provide remarks that consideration should be given to individual patient characteristics. Again, this is a conditional recommendation where contextualization is important. We talk about the importance of frequent ongoing assessment of patients to avoid harms of under or over resuscitation, and then also specify that this really should be based on actual body weight. That's particularly important for underweight patients, or adjusted or ideal body weight in our obese patients. So a lot more kind of nuance and contextualization, but really kind of high-level summary recommendation, unchanged from prior. In terms of MAP target, there was some revision here. So specifically, MAP target being reduced for older patients. So recommendation 13, we suggest a MAP target of 65 over higher targets, moderate certainty evidence. We have this remark about how you can't maintain a MAP at an exact number, and therefore you should use a range of something like maybe 5 millimeters mercury. And then we have a suggestion that when it's an older patient, 65 years or older, we suggest using a MAP range that's on the lower side, 60 to 65. And that's predominantly based on the 65 trial, which looked at patients with distributive shock, overwhelming majority being septic shock. And in Bayesian analysis of that study, about like 85% probability that using that lower MAP target is associated with a mortality benefit. And I think here it's like important to recognize this isn't meaning like this isn't a sick patient, they're not in shock. Of course they are. This is really trying to think about the risks and benefits of, giving a vasopressor infusion versus allowing permissive hypotension and sparing the amount of vasopressor exposure to older patients. And it seems that sparing that vasopressor exposure appears to be the safer way to go. Again, low certainty, it's possible more data could change that, but that's kind of the best data we have on the topic right now. All right. For antibiotic timing, these are like the sort of highest profile recommendations. There's a number of sort of statements related to this. These are all consistent with 2021. So we've tweak some language, again, always kind of trying to achieve greater clarity. We've brought in these kind of terms about definite, probable, possible sepsis, recognizing that when patients first come to ICU or first come to the ED, a lot of times this is kind of like an evolving sort of process in terms of, gosh, they're undifferentiated. Maybe it's sepsis. Oh, gosh, I really do think it's sepsis. Oh, yeah, definitely. And so we spent a lot of time kind of workshopping this. But basically, definite or probable means like this is like the number one thing the patient has. Possible means like, okay, we're this or that, you know. So if you think this patient has sepsis, that's the number one working diagnosis, give the antibiotics immediately, ideally within 1 hour. And then in these often circumstances where sepsis is possible, the guidelines will recommend stratifying this based on shock, or like how I extrapolate that to clinical practice is really based on whether they're presenting with hypotension. So if this patient is hypotensive, you know, we know that for each hour of delay, that there is, you know, a measurable increase in mortality. And so the recommendation is to give antibiotics immediately, of course, continue to help, you know, evaluate, determine what it is, and stop the antibiotics if it turns out to be something else. But we carve out this time for rapid assessment of infection versus non-infectious causes of illness for patients when sepsis is possible and shock is absent. And that's really trying to help like improve implementation and get out of this kind of cycle of, well, gosh, maybe it's sepsis. I only have an hour, better give antibiotics, premature closure. We want to sort of recognize this evolving certainty in practice and try to, you know, use that to help stratify like the next steps in management. Kind of following along this framework, we have a new and quite narrow recommendation for pre-hospital antibiotics. So this is a suggestion that for patients with probable sepsis, meaning like based on their pre-hospital evaluation in ambulance, it seems very likely that sepsis is the most likely diagnosis. They are hypotensive, and you know that you have a prolonged transport such that this patient will not be evaluated for over an hour. We suggest giving antibiotics in ambulance. We do have a remark that this should be implemented only after the screening process for sepsis, you know, previously recommended on the prior slides, is already established. And this has gotten like a fair amount of, I would say, some pushback from the emergency medicine sort of community about, you know, like widespread use of antibiotics. And so again, it's just, this is a very narrow recommendation and is completely in line with the in-hospital recommendations. And I've also heard from like sort of people around the world in high income settings where they have like large areas of rural practice and prolonged transport, like in Norway, in New Zealand. You know, people are like, oh yeah, we've been doing this for years. Of course, you know, you have a patient, they're hypotensive, they're very clearly septic. It's going to be 2 hours till they see the doctor. Like, of course we give antibiotics. How could we not? So it's interesting how, you know, it was controversial to some people, but other people are like, yeah, this is of course what we would do. It makes good sense. So I think that this, you know, again, follows along what we know about the risks of delay in patients once hypotension has already been established. All right. In terms of next sections, antibiotic selection and management, I think just like globally, there has been this evolving greater focus on antibiotic stewardship. Like there's been a lot of focus on time. And I think over time, as the guidelines have evolved, you see less language about broad spectrum and more about sort of careful selection of those antibiotics. So one area of revision is we previously had like paired statements like suggest using empiric antifungals in high-risk patients, suggest against in low-risk patients. But fungal sepsis is really quite rare. And even if you look at high-risk populations and enroll them into studies, very few of them ultimately end up to have confirmed fungal sepsis. So it's really hard to identify a high-risk population. And so we've now simplified this to just say we suggest against using it. And we sort of manage these very sort of narrow cases with a remark just like, yes, consider this on a case-by-case basis in those high-risk patients, but this should be something that you should really be doing only in a very minority. So the way I do this in my practice is I will start people on, you know, antibacterial coverage. I watch these patients very closely. Like you want to see that if you give good resuscitation, if you get patients on antibiotics, if you do source control, you should start to see signs of improvement. If it's been like 3 and 4 hours and this patient is continuing to deteriorate, you know, something has been missed. Either it's a coverage issue and you want to think about broadening that, such as antifungal coverage, or, you know, confirming that there isn't a missed source control issue. So I kind of will add this on at my sort of like, you know, 3 and 4 hour recheck when I'm really hoping to see that my patient has started to turn the corner. All right. Next, this is a really brand new PICO question, new topic, we asked about empiric anti-anaerobic coverage. There's been sort of growing attention to this area. And we have a paired statement suggest against using empiric anti-anaerobic coverage in patients with sites of infection where it would be very unlikely that there'd be an anaerobic infection. And that's like the vast majority of like pneumonia or urine infection. And then, of course, suggest using it in patients at higher risk. So that would be like intra-abdominal or necrotizing infection. And I'm going to walk through a little bit more background on this one because, again, it's like a newer area. And this, I'll highlight some research that's been done at U of M related to this. So first, there are a bunch of preclinical experiments that show harm with giving anti-anaerobic antibiotics and like resultant depletion of gut microbiome, and that has negative like downstream impacts on ability to resist infection. So this was a cool study. This was done by Joost Wersinga and colleagues in the Netherlands. So they took mice, they randomized them to getting antibiotics or not, just pre-treating them. And then they stopped the antibiotics, they waited a few days, and then they gave this intranasal streptococcus instillation to essentially give the mice sepsis. And there was a big difference in survival. So these mice that had been pre-treated with antibiotics, gut microbiome had been impacted, they died at greater rates compared to, again, genetically identical, maintained the same way mice who had not had this pretreatment. So there's like experimental evidence suggesting that this depletion of microbiome has downstream impacts. In practice, we also know that there's this big discordance between what we are covering with antibiotics and what ultimately is the causative pathogen. So this is from the EPIC-3 study. This was like a large point prevalence study that was done in about 1,100 ICUs in 88 countries, where only 1% of patients had anaerobic pathogens identified in their evaluation, but about half of all of these patients in all of these ICUs were receiving anti-anaerobic coverage. So this is something we do very commonly, despite it not often, being something we're specifically targeting. All right. And then in this study, this was a study done by Rishi Chandraraj. This is an infectious disease doctor at University of Michigan. So in our ICU, when everybody comes in, they get a rectal swab. This is done for VRE screening to surveillance in our unit. And those swabs have then been banked and can be used in research. So among these 3,000 patients who had had these like banked rectal swabs, 64% of them had been treated with anti-anaerobic coverage. And there was marked difference in this essentially gut microbiome that was measured from this rectal swab taken on admission. So about 100-fold decrease in bacterial density and domination by like pathogenic species. So good bacteria are gone and like pathogenic species are now present. And again, like, these people aren't randomized like the mice, but these were big differences and correlate with sort of the antibiotic treatment that they'd gotten in the emergency department. And then the patients who had had this anaerobic coverage had increased mortality. Again, like observational study. But this follow-up study was very cool and used kind of like a stronger observational method. They took advantage of this natural experiment. So in 2015 to 2016, there was a national shortage such that piperacillin tazobactam or Zosyn was on national backorder. And so this is a figure showing the use of antibiotics in our hospital. So it's about a 1,000-bed hospital. And this maze line here shows on any given day over time what proportion of patients in our hospital are receiving piperacillin tazobactam. It's like a quarter of patients, right? Clearly, this is like preferential empiric coverage here. And then, 5 to 10% are receiving cefepime. And you can see that during the shortage period, suddenly like practice flips overnight. So this is this kind of like exogenous event unrelated to the patient case mix or characteristics. So in this study, we looked at patients who had come in with sepsis, empirically started on vancomycin and either piperacillin tazobactam or cefepime, excluded a bunch of patients who had sites of infection where anaerobic infection is plausible, and were left with about 7,600 patients for whom there is reasonable clinical equipoise about which of those antibiotics may be better. And then in this instrumental variable analysis, it essentially isolates the effect of this coverage choice. And there was about a 5% absolute mortality benefit at 90 days for patients treated with cefepime versus piperacillin tazobactam, which was robust across like a number of different sensitivity analyses using different approaches to modeling. So again, like really consistent with this preclinical evidence that sort of coverage of the, anti-anaerobic coverage has negative downstream effects. And I'll also say that this looked at 90-day mortality, and the separation really occurs between like day 14 to day 90. This is not this immediate effect or sort of failure to cure the initial infection. It's really like depleting the microbiome and allowing this like secondary infection to come into play. So I think practical implications are, where possible, we should be selecting antibiotics that have lesser anaerobic coverage. So if it's community-acquired pneumonia, treating with standard like ceftriaxone and azithromycin and resisting our temptations to add something like metronidazole or clindamycin that sometimes people will add for, aspiration or coverage of anaerobes. I think increasingly like pneumonia guidelines will say like, don't do that. But I think it also is about, when picking your gram-negative coverage, picking things that in general just cover gram-negatives, and where feasible, based on antibiogram and other factors, picking things that have less anaerobic coverage as opposed to strong anaerobic coverage. So I think this is something that like a lot of times gram-negative coverage is prescribed, comes part and parcel with very heavy anaerobic coverage, and we don't really think about it. And so the guidelines really trying to sort of open the mind to sort of think carefully about the coverage spectrum being prescribed. All right. Last recommendation about stewardship specifically is just an upgraded strength of recommendation. So we now have a strong recommendation that antibiotics should be de-escalated, meaning narrowed or dropping certain agents, once the microbiology diagnosis and susceptibility profile is available. We also have upgraded strength of recommendation regarding prolonged infusion of beta-lactams after the initial bolus loading dose. So that's like a 3-hour extended infusion time. And that's based on moderate certainty evidence, meta-analysis about 9,000 patients, moderate certainty that there reduces mortality. All right, so on to hemodynamic resuscitation. I think this is a really important recommendation and was upgraded in certainty from very low to low certainty. And this is a suggestion to use dynamic assessment of fluid responsiveness to guide ongoing resuscitation. So there's a lot of attention to those first 30 mLs per kg. That's really just a pragmatic suggestion to get you going. But as for patients who remain hypotensive, the recommendation is to at that point transition to use dynamic assessment. So this would be assessing a change in cardiac output or stroke volume in response to a passive leg raise or fluid challenge. So here this shows a passive leg raise. Patient is in bed and you completely move the bed such that now the legs are in the air. This is like important that it's the bed moving and not the patient, because that will give you erroneous data. And then this figure here shows how the change in the stroke volume is dependent on both the preload as well as the patient's ventricular function. So this is really an excellent test to say, will my patient have a positive response to additional fluid? There's 2 prior very large and high-quality systematic reviews showing that dynamic assessment with a passive leg raise is exceptionally good at predicting whether cardiac output will indeed increase with fluid bolus. So sensitivity and specificity pooled across the studies like 0.85 and 0.91. And positive and negative likelihood ratios, again, very high and very low. This is like a very good diagnostic study. And exam findings, particularly things like peripheral edema, really do not predict responsiveness. So high quality evidence that this predicts what will happen as I give fluid. And then additionally, because again, I've kind of stressed the importance of patient-centered outcomes here, there's also, I would say, really emerging evidence that using this kind of serial dynamic assessment to guide resuscitation improves outcomes. So we updated a number of prior systematic reviews. So we looked at a total of 18 RCTs where fluid management was guided by serial dynamic assessment. And this is associated with lower mortality, which was moderate certainty, and less progression to needing renal replacement therapy, also moderate certainty. And this is a pretty heterogeneous study, so variable patient populations, studies will use different criteria to define this like line in the sand of fluid responsiveness. Is it plus 10% in stroke volume or plus 15, or is it cardiac output? But this kind of general approach, when pooled together, shows this like consistent signal for better outcomes. People, of course, want to know, well, what device should I buy to do this? And so we did look into trying to make a recommendation about specific non-invasive or minimally invasive monitoring devices, but made a statement of insufficient evidence. So these are some of the non-invasive examples. This is the Baxter Starling device. There's this ClearSight finger clamp, this flow patch. All of these are completely non-invasive ways to do these kind of assessments of stroke volume and assess for change with a passive leg raise. And then I don't know if you guys have ever used these PICO devices. I haven't. This is pulse index continuous cardiac output. These are very common in Europe, but they allow for continuous cardiac output monitoring. They do require a central line and an A line, which is often put in femorally. And I guess there are a few hospitals in the US that use it, but I guess it's been so like little uptake that they haven't been able to maintain support for the US, like the help desk of like if you're trying to troubleshoot your device. And so they don't even sell new devices in the US. But it's interesting, like on this panel, like in Europe, they're like, oh yes, all of our patients or a lot of our patients, like we have them on these. So like huge variation, around the world in terms of what people are doing, but really no kind of like head-to-head data on what device would be best. And of course, you can also use cardiac ultrasound, but again, you have to be like quite well trained to be looking at, to like specify the exact change in a stroke volume or cardiac output. So that's often, there's like less availability, middle of the night for that kind of degree of echocardiogram competency. In terms of fluid type, we have upgraded certainty. So we still have a conditional recommendation, a suggestion for balanced solutions. But I will highlight that this increased from low certainty to moderate certainty for a mortality benefit. So we did have a fair amount of discussion about whether this should be a strong recommendation. And one of the things that I think led to some pause was this statement about the implications, and that if it's a strong recommendation, it really means like you shouldn't be doing more research on this, and also awareness that there's still a lot of like trials out in the field, and we didn't necessarily want to imply like, oh my gosh, these all need to be shut down. And so this ended up landing at a conditional recommendation, a suggestion, but I would say has probably stronger evidence behind it than virtually any other conditional recommendation in the guidelines. All right, vasopressors. I'll sum this one up quickly because really little has changed, and all of this is like pretty much low or very low certainty evidence. So we continue to recommend norepinephrine as first-line vasopressor over dopamine, epinephrine, celepressin, and we suggested over vasopressin and angiotensin II. There's less evidence there, and that's why that's a suggestion. We suggest adding vasopressin if escalating doses of norepinephrine, so that should be the second line. This was one of the areas where, the question comes up, well, when do I add it? And there's, little data really at that point about the optimal time. And so we surveyed our panel to ask what they do. And the median dose was 0.3 micrograms per kg per minute with a range of about 0.2 to 0.5, which was like fairly close to what was published in the OVIS study, which was an observational kind of like machine learning study published in JAMA last year, I believe, that found that for the median patient, the optimal dose was about 0.2 with a range of about 0.8 to 0.45. So somewhere in that neighborhood. As third-line vasopressor, we suggest adding epinephrine if still on escalating doses. Interestingly, only 55% of the panel adds that as a third-line vasopressor. Other places, either multiple vasopressors are not available. I think in Europe, a lot of people are using angiotensin II based on kind of like theoretical benefit of multimodal vasopressors. And then typically this is being added quite late, so 0.8 micrograms per kg per minute, and really an area where like data is very skimpy. All right. And then for steroids, we have a suggestion to use them for patients with septic shock. In hindsight, I wished we had asked a little bit of a more like, I don't know, compelling question, like, well, what about fludrocortisone, or at what dose? Or anyway, it's hard to course correct when you discover this, right, as things are like already done with the systematic review and evidence synthesis. So we ended up doing like a really like in-depth panel survey to get more nuance here, which I thought was kind of fun. So 90% of patients, panelists, are using 200 micrograms of hydrocortisone on a 24-hour basis for patients in septic shock. So really widely used across the world. Most people are dosing this intermittently, like 50 micrograms every 6 hours. And then the median sort of threshold that people are adding it is on a dose of about 0.2 to 0.3 norepinephrine. So like that same time when you're adding vasopressin. medicine, or after about 2 to 4 hours. So they're on like a real dose of vasopressors for at least a few hours. And then 63% never use fludrocortisone, 26% sometimes, and 10% usually or always. I will say I fall into that camp just because I think there's pretty good observational target trial emulation data, which again, falls into this low or very low certainty evidence, but I think is the best we have. They're very unlikely to cause harm and very inexpensive. So it's something I do, and I wish in hindsight we had maybe addressed that more formally as opposed to merely in the panel survey. And then we asked about stopping and tapering, and there was kind of a mix there. And I do that on a kind of a case-by-case basis. Robust blood pressure, great. Cold turkey, kind of puny, barely off norepinephrine, okay, half dose for a day, then off. So kind of do that on a patient-by-patient basis. All right, so closing up here, I just wanted to draw your attention to this figure that I think is meant to be like most helpful for people kind of like overnight or trainees. This is not like an exhaustive summary, but this is the sort of key sort of pragmatic like daily recommendations for monitoring initial fluid resuscitation and vasoactive agents, and then what to do for patients if their hypotension or lactate elevation persists after that initial fluid resuscitation. People often ask about like, well, what generated the most internal panel discussion? And I will say it was not 30 mLs per kg or antibiotic timing, where essentially the Algonians are like, yep, we think this is the right thing. We're going to keep doing this. Things that generated discussion were this antibiotics in ambulance, and it was a lot about getting the words right about who that was meant to pertain to. A lot of discussion about invasive versus non-invasive blood pressure monitoring. We have a conditional suggestion for either or. It used to be just suggest invasive if they're in shock. We've kind of liberalized that, and that was quite controversial. And it really was less about the accuracy and much more about what is more comfortable from a patient perspective, having an A-line or having a cuff cycle every 15 minutes. So people have differing opinions about which is less comfortable. But we ended up with an either or suggestion. Methylene blue, we have a statement of insufficient evidence. There was a lot of debate about whether there was sufficient evidence to suggest use as a potential rescue therapy. It's used in a lot of the world where there's really limited access to vasopressors and some evidence that it shortens duration of shock, but really essentially no data on whether it impacts mortality. Zhubijing was a challenge. This is a traditional herbal Chinese medicine that involves like 5 different plants that's widely used in China, but was sort of a struggle to evaluate the literature. And ultimately, we kind of have this bland statement about, recommend against use in areas where it's not approved, which of course makes sense. You wouldn't otherwise use it. But I don't know, there's a lot of data, and I think it would be really important to study this outside in like in a new country to move the field forward. This should say pulse ox target. A lot of discussion here. Ultimately kind of ended up with this like broad range of, somewhere in the middle. People felt strongly we should be trying to restrict. Other people felt strongly that, there's like maybe like a 0.01% benefit with higher oxygen. So lots of discussion, but ultimately recommend kind of this 90 to 96% range. Awake proning, also lots of discussion, but we have a conditional recommendation for that. All right, last 2 slides here. Just pointing out that we do have an interactive guideline so that you can check this out on the website where you can click right to the section you want. You don't have to read it in entirety. And then we also have a free app that you can download that has the guidelines that, again, like take you to right where you want. So, well, thank you all, and I'm welcome any questions.
Hello. Thank you so much, Hallie. That was a great talk. The floor is open for questions. Okay, a lot of questions.
Thank you very much. That was amazing. And I could just imagine how much hard work you put into this. So my question is about the anaerobic coverage.
Yeah.
And so I'm sure we're not the only hospital in the world where everybody gets Zosyn when they're infected. And I'm curious from the perspective of more of like implementation science. So very compelling data that you shared, but also not at the level where we could say this is like a high degree of evidence.
Mm-hmm.
And so I'm curious, how do you move the needle it's hard enough when you have high level evidence to get people to follow recommendations. It's quite another to say, like, can I go to this hospital tomorrow or go to my friends in the emergency department and say we need to totally change how we're doing everything based on data which are not really strong.
Yeah, I mean, I shared some of it. I mean, there are some like older trials that like randomize people to getting like plus flagell or not. You know what I mean? So they were like much older clinical trials. There was other stuff that went into that evidence synthesis. I would say like you sort of, you know, right. This is not something that's probably ready for like a performance measure or some kind of like rigid enforcement. I think you can start by saying like, you know, I don't know. People were getting like clindamycin and flagell, for example, added. I think that's like the place to start. Like for people who like have an aspiration pneumonia, like pneumonia guidelines don't recommend that. That's probably the place to start is the things you're very explicitly prescribing for. Anaerobic coverage. And then when we think about sort of these like general, like all cause gram negatives, I think it's more like this should be part of the equation when you think about antibiotic selection. I think other things that we need to think about are like the local antibiogram, and like the antibiotic stewardship literature says like very clearly that antibiotics need to be, there should be local hospital guidance about like sort of a hospital protocol and maybe sort of order sets that sort of, you know, like, sort of send you down the right pathway. I think unfortunately right now, a lot of it's like knee jerk, right? Sepsis, vancomycin. And I think like we need to sort of move away from that, but it's probably going to be sort of like baby steps to do that.
A quick follow-up question to that. So I think it's one thing to treat within an hour. You have to make a decision. And you know, the worst thing you could do is not cover the organism in that first hour. It's quite another to say, okay, now they're in the ICU and the dust is settling and you can start to be more thoughtful about your antibiotics. So how much of the concern has to do with getting any anaerobic coverage versus getting a first dose that does cover anaerobes and then you narrow?
Yeah. So, I mean, I think there's like different arguments, you know what I mean? Like, I think some people will be like sort of purist and say like, well, that first dose is the most dangerous because you've done massive harm. But I'm like, you know, this is like a very much of a shades of gray and some is always better. You know what I mean? So like restricting it like on day 2 is still better than just like running people on long-term broad spectrum antibiotics. So again, I think we kind of need to like chip away at the problem. And that's like, I don't know. I think we don't really have good data on like which of these are the most microbiome depleting. Like, so like my colleague Bob Dixon has done some research on this, like giving single doses to mice and then measuring it to sort of grade it. But I'm like, I'm not convinced that like what happens to human is like that we can directly translate this mouse dosing and mouse microbiome to like what happens to human. And there's actually like vanishing little evidence. Like if you think about like ceftriaxone versus unit, like all of these different things, like we know cefepime is very sparing and we know zosyn is very like depleting, but there's lots of shades of gray. These aren't really like dichotomous. And we actually don't have good like data on the sort of relative intensity by which these things deplete it. And so I think that's just like a general like area we need to go to. And then think about just like adding this as like one of the pieces, like you have allergies, you have your local antibiogram, but you also think about like covering the things that are likely, but we've spent less attention to like, and not covering the things that are unlikely. There's just sort of just been general this like thought that, you know, you do harm by not covering the pathogen, and like stewardship is all about this kind of like global threat of antimicrobial resistance. But I think there's growing evidence that there's also like direct harm borne out to the patient by unnecessarily broad coverage. Yeah. And like, again, chipping away at it. We're not going to sort of solve it all in one day. Yeah.
Okay. Can you hear me? Yeah. Okay. My question is about something that gave me palpitations when you presented these guidelines at the FCCM Congress in March, and that's the MAP 60 to 65 recommendation for older adults. And as some of you might know, it sort of stood at odds with the inaugural, the FCCM guidelines for caring for critically ill older adults that Lauren here chaired. And I had the privilege to observe that process as vice chair. And, you know, I witnessed that thoughtful discussion that went around about how do we make a recommendation with results from one trial. And it was really reassuring to hear you clarify that you preemptively specified that if anything was even low certainty evidence, we will make a conditional recommendation.
Yes. Yeah.
And that's really reassuring to see. And I'm curious what your thoughts are about the future of guideline development process. Like, do you see ourselves do you see us striving towards a unified framework where recommendations mean the same thing across panels? Or do you think a more realistic approach is being transparent in how these decisions are derived within a guideline?
Yeah, I guess I would kind of say it's like a yes and. Like, yeah, I think that transparency is super important. And so, like, one thing that's really different from the 2021 guidelines versus now is like pretty much all methods were fully relegated to the supplement. And we sort of fought to bring those forward because I think a lot of the confusion, like, or sort of like misunderstanding of guidelines comes from the fact that people don't really understand kind of how you got where you are. And so we wanted to bring that in. We recognize it's already long enough. People don't want to read the supplement. So trying to sort of elevate that. I think that, there are these like kind of guidelines for guidelines, like these like trustworthy clinical practice guidelines. So I think there is a general movement to go there. At the same time, I think there's like, reasonable reasons to sort of disagree. There are certain countries that are sort of more apt to sort of look at expert guidance. And there's also sort of areas where there's like, the limitations of the evidence. And that's also why we tried to bring in these panel surveys. And again, be really transparent. Like, these aren't recommendations. And those are, they're controversial. Some people think like there's no place for the panel survey. This is just totally random 69 people's opinions. But I also think it's like a disservice to the field to just be so rigid and say, oh, nope, can't say anything, can't say anything. You know what I mean? So I think transparency absolutely is important. I think there's a general motion for transparent clinical practice guidelines, but I think there always will be these kind of like expert consensus guidelines because you're trying to cover the landscape of areas that are just like not well covered by, high certainty evidence. Yeah.
Thanks for bringing that up. I mean, I will say, like, I do think it's a lot of things being relegated to the supplement is a problem. We did put a lot of the rationale for our guideline recommendation in the manuscript because we got wind that our recommendations were going to be contradictory.
Yeah.
But even then, that wasn't enough space to like fully explain. I mean, for us, that was our most controversial and discussed guideline. We actually had two specific meetings on it. And I think also the other thing to keep in mind is the first step of grade is the panel prioritizing outcomes. And for the older adult guideline, although we still included traditional outcomes like mortality, we also included things like functional outcomes, cognitive outcomes. There were some concerns about signals with the cognitive outcomes in the 65 trial. And so our no recommendation statement is really a call for future research, which I don't think is contradictory to what Surviving Sepsis would say, right? Like, we would all welcome more than one trial on this topic.
Yeah, no, I totally agree. Yeah, I think like the fact that you focus on only 6 to 7 outcomes is a lot of times the explanation for why things differ. And I also think like more often than not, they're sort of like, there's more agreement than disagreement. And so we didn't catch wind of your guidelines ahead, but we did try to comment wherever our guidelines were consistent with previous published guidelines or where they were discordant, like ESICM fluid guidelines recommend up to 30 mLs per kg, which is pretty nebulous. We sort of explained the differences, of why, and how these are actually more similar than different. Yeah.
Thank you for a very clear talk on a complicated topic. And actually, about the 30 milliliters per kilogram, I wanted to ask a clarification question. I'm wondering if what your impression is in terms of, or if there's data to suggest the relative risk of harm for do not under resuscitate, do not over resuscitate, because it's a very confusing issue. Oftentimes, in my training, I was more commonly taught it's better to over-resuscitate because we could diurese and intubate than under-resuscitate. But is there any evidence to support that or against it?
Yes. So it's a great question. And I totally agree. I think like to a limit, it is better to over than to under-resuscitate. I'll talk about my research talk tomorrow, but I'll be sharing some data. We've looked at this in our registry and have a paper that's in press and coming out in June, but sort of maps out the risk-adjusted mortality by mLs per kg of fluid volume. And you can see this very clear in our registry data that as they get more fluid, mortality goes down. And it's definitely higher for the under-resuscitated patients. And that's, these are both matched and risk-adjusted. So we sort of again, it's observational data, but you try to do everything. And I will say, yes, for the sepsis registry that I run for the state, I do site visits. And so I go out and visit hospitals and walk their process. And we're able to look at our risk-adjusted sepsis mortality at the hospital level across the state. And so if you go to like our very best hospital in the state, there's a large community hospital, and I'm like, tell us what you do. They're like, they come in with sepsis, we give them 30 mLs per kg. Like, we don't wait for the lactate to come back. We give it because sepsis needs fluids. And we actually, when we initiated this initiative, the reason we did it is because we looked at our patients who did poorly. And these were typically patients who came in and their blood pressure was like 100 systolic, so they weren't below 90, and their MAP wasn't below 65, and they got their antibiotics, and they were called up to the ward, and the ED doc went on to the next patient. And then this patient slowly started to go downhill, and then you're kind of behind the 8 ball. And so we worried that we were just too late. And so we said, you know, most of these patients, like the lactate ends up coming elevated, or their blood pressure was lower than normal anyway, and 30 mLs per kg is really not that much. So they just rolled it out across the board and saw like this immediate decline in their mortality. And they said, like, the main reason people don't give fluid is they're afraid this patient will get pulmonary edema, they'll end up on oxygen, they'll have to go to the ICU, and the ICU will make fun of them. Why did you give so much fluid and do this to the patient? And so they got their like ICU docs to go down to the ED, like, we totally agree, this is the right decision. If the patient needs to come to the ICU, of course we'll take them. So that's the best hospital. If you go to the hospitals with the highest risk-adjusted mortality, they're exceedingly cautious. They're like, well, you know, fluid can cause harms. We give 500 mLs, and then we go check on the patient again. And then we give another 500 mLs, and then we come back and check on the patient. But we all know how like busy people are. You're tied up with another patient. These patients like smolder along in shock for like a really long time. And we know that the longer patients remain with this kind of like puny blood pressure, the worse they are. So we see like stark differences in just sort of the general approach to like treating patients across the like relative like sepsis performance across hospitals. And so that's been helpful to kind of like shifting statewide practice to being more like proactive and pragmatic and less sort of like cautious and afraid. Yeah.
Hi, thanks. This is a great talk, and really reflecting on the consensus process. It's amazing seeing how many stakeholders you've had, and you know, the fact that all those methods are in an appendix, hearing specifically that you have you know, patient voices in there and the breadth of international voices as well. So I'm wondering if you could comment kind of on the fringes, some things that you think might not have made it in there if you didn't have such a wide swath of stakeholders, but then also for your own specific practice, maybe in Ann Arbor or New Haven, things that maybe are in the guidelines that we might want to take pause for our local practice.
Yeah, it's a great question. Yeah, so we have a new suggestion for active deresuscitation, like using diuretics to like offload volume overload at the end. And I will say there's like only very low certainty evidence there. And so it's possible we could have had a statement of no recommendation. But I will say that when every single statement before it went to the full panel in-person meeting went through the patient panel, and we said, well, this is our draft statement. What do you think? Edema is very upsetting to patients. They feel like passionately like they want it gone. And so that was like helped sort of elevated that. I will say like we wanted to essentially literally say there should be no more research on vitamin C because it's a waste of research dollars. And the patients felt very strongly that that was like inappropriate. They're sort of like, I don't know. It's, you know, it's cheap and it's a vitamin and it's good. And they just sort of are like, it can't be in there. Like, and so we even wrote like, you know, something about like that this was like sort of a very appealing topic to the patients. So yeah, the patients are very savvy. I mean, I think they were, you know, some guidelines will like embed individual patients within different subgroups. And we had a separate patient panel to kind of like amplify their voice because it can be very intimidating to be this like one patient. But we had people come and present their stuff to the patient panel. The patient panel was all together and had people from Australia, Europe, and the US. And so that kind of gave them like the power to like, you know, push back because they were typically the majority in those meetings with them. So that was really cool. And then in terms of stuff around the world, I think that like technology, like I sort of talked about that Pico device, like, I mean, in Europe and Australia, I mean, they're like, these Pico devices are like everywhere and I've literally never used them. So that was really kind of eye-opening to me, seeing the differences in that. I think there's also areas of the world where, you know, in Europe, you know, really it's 1-to-1 ICU nursing. Here, it's either 1-to-1 or 1-to-2, but that's not the same around the world. And so we have this, you know, suggestion that you should initiate vasopressors peripherally as opposed to delaying until you have a central line placed. And we talk a lot about like the evolving literature about the safety. And I think there is really like growing data that it's safe to continue to administer vasopressors through peripheral lines, but that's if and only if you have a nurse or a monitoring protocol that they're able to see that and look for a strap fixation. And so people practicing in South America were like, there is absolutely no way that anyone is ever going to be able to monitor that IV. So like, we are never going to do this. And so again, it's sort of highlighting like, this is safe, but if and only if you have a monitoring protocol, you stop it as soon as it extravasates, you have a protocol to treatment. Because ongoing extravasation, yeah, that does cause harm. It's just as long as you're checking it every 2 hours, and that's feasible in all like many high-income country ICUs, it's not feasible in other parts of the world. So I thought that was like incredibly important to have like all of these different settings, and also like, yeah, to have nurses and physicians and pharmacists and a physiotherapist, like having different sort of disciplines as well too was, I mean, I learned a ton from people. We even had like one of the nursing professional societies. You get like amazing people that are put forward by these professional societies that you might not know in your own network. So one of the American like critical care nursing societies put forward someone who was a former ICU nurse, but she now works as a hospital sepsis coordinator in a big community hospital. And like she had a very unique perspective, really from like a QI, you know, sort of perspective. So that was super cool. So yeah, great question.
First, I want to thank your committee. What a tremendous effort. And I like the idea of the international flavor. I have a big overview question. We know that when the ARDS group came forward with a low tidal volume, we saw a significant improvement, perhaps in outcome. Where are we in the big picture of sepsis? Have we made big improvement? What improvement have we made nationally and globally, or do we know?
Yeah. No, it's a great question. So I think like, yeah, for ARDS, like low tidal volume ventilation was almost like a step decrease in mortality, right? This really like single intervention that made a big difference. And I can't say that like, if you look over the past 25 years of sepsis, there's been this like one single intervention, but I saw this great talk, Derek Angus, like 2 years ago at Critical Care Canada Forum. He was tasked with like the past 25 years in sepsis. And he was like, are you familiar with the concept of compound interest? And he was sort of like, you're chipping away at it, right? Like you're getting better at timeliness, you're getting better at recognition, right? And you think about like, I don't know, I think that there's been such an attention to early diagnosis and early treatment. We don't see these people who've been in shock for hours and never got antibiotics, right? So I think there have been a lot of sort of improvements into the way we deliver supportive care, hospital sort of system-wide, recognition of the, but yeah, we're waiting for our low tidal volume to.
All right. So on that note, we're going to close questions. Thank you again, Hallie.